Hi, everybody. Welcome back to Patho-Mnemonic. For those of you who are new to this, my name is Peter. I'm a fourth year med student. This is an NBME shelf exam and step two content review series. Each of the episodes fall within like the certain purview of a shelf exam, and then all of them fall within the content of step two. So I think at this point we have reviewed all of the, or not all of, but we've gone through review for all of the shelves except for Family Med. So I wanted this episode to be focused on Family Med concepts. Um, and so we'll go ahead and get started. Um, Uniquely for family medicine, there's a lot of USPSTF screening guideline suggestions. Um, and honestly, I think the best way to remember this kind of stuff is to just like either make flashcards or um, honestly, in my case, it was just flashcards to just see the age demographic and clinical indications for each screening test. Um, so anyway, we'll just do some practice here. Let's say, for example, there's a 70-year-old male that has a 20-pack year smoking history from when they were 30 to when they were 50 years old. So they quit 20 years ago. What do you get for this guy? So he is within the age demographic and clinical features of a 65 to 75-year-old man who has ever smoked. And so in that demographic, they get a one-time abdominal ultrasound to screen for an abdominal aortic aneurysm. Um, let's say, for example, there's a similar patient, again, 70 years old, again, with a 20-pack year smoking history, but in this case, they're still smoking. So the demographic changes a little bit. In this case, it is for any 50 to 80-year-old adult with a 20-pack year smoking history and they're still smoking or they quit within the last 15 years, they get a low dose chest CT to screen for lung cancer. Um, you see there's like some crossover between the abdominal ultrasound and the low dose chest CT. Um, in some cases, you might actually make the recommendation for both. So in this case, this 70-year-old male with the 20-pack year smoking history and is still smoking, that also fits within the demographic that gets the one-time abdominal ultrasound. So in addition to the low-dose chest CT, this guy would also get an abdominal ultrasound. Um, so that's like smoking stuff. The next thing that comes up a lot on family medicine is screening guidelines for things like breast cancer. You get a they talk a lot about mammograms. So you start mammograms at age 40. So from age 40 to 74 every 2 years. And then that's assuming there's a negative screen each time for like the average person at risk for breast cancer. Where things get a little different is if there's like a personal or a family history of breast or ovarian or tubal or peritoneal cancer. Or if there's an ancestry of a confirmed BRCA1 or 2 mutation. So if any of those features are positive, um, then the first thing that you do is actually genetic counseling. You might be tempted to pick immediately just go to BRCA1 or BRCA2 testing. But the USPSTF suggestions are to start with genetic counseling first. Okay. Um, Similar to breast cancer, like health maintenance for women, are pap smears. So you start pap smears at 21 to 29 years old. So starting at 21, and then within the age range 21 to 29 years old, you get a pap smear every 3 years. So the way that I remember it is pap for pap smear has three letters, 3 years. Once you get to 30, things can change a little bit. So from 30 to 65, you can continue with getting a pap smear every 3 years, or you can get a co-test where it's like the pap smear with a high-risk HPV screen, and you get that every 5 years. So high every five. There's a bit of a rhyme there. That's how I remember it. Okay. Um, let's say, for example, there's an 18-year-old female who presents to establish care, and then, in confidentiality, she says that she's sexually active. So, what screening things do you recommend for her? Um, so, all sexually active women younger than 24 years old, younger than or at 24 years old, you screen for chlamydia and gonorrhea. Um, if they're once you get to 25, and then as you continue on from 25, you only screen for chlamydia and gonorrhea if there's an increased risk for infection. So if they have like risky sexual behavior, or if they have multiple sexual partners, so on and so forth, then you would screen for chlamydia and gonorrhea. You also screen for chlamydia and gonorrhea if they're pregnant. And coming up soon, we'll go over like all of the screening tests that you get um, during pregnancy. Another thing that you want to screen for in this patient, so the universal demographic is if it's 15 to 65 years old and they're sexually active, or again, if they're pregnant, you also screen for HIV. So this 18-year-old female not only gets chlamydia and gonorrhea, she also gets HIV screening. Okay. Another thing that comes up a lot on family medicine is osteoporosis. So um, starting at 65, so 65-year-old females, you start with a DEXA scan, and then that, like, you interpret the Z score to determine like the standard deviation of their bone density, to determine if they have osteoporosis. Okay. Another thing that comes up a lot on family medicine and USPSTF stuff is prediabetes and type 2 diabetes. Um, so you screen for these conditions in 35 to 70-year-olds who have an elevated BMI. So if they're overweight or if they're obese. Um, and so obviously, I mean, you need to know like when to screen for prediabetes, but there's also the diagnostic criteria of type 2. And this is applicable to family medicine, internal medicine, peds, surgery sometimes. So it's very like universal. And so that's if there's a fasting blood glucose at least 120, um, or if there's a random blood glucose at least 200 with symptoms. So that includes like thirst, like thirsty all the time, or polydipsia where they're just constantly drinking, polyuria where they're peeing all the time, or nocturia where they're peeing at night, weight loss, or if they have like blurry vision. The reason why you need to have these symptoms is because anybody that like, let's say for example, someone who doesn't have diabetes has like a really big lunch and then they go and get a random glucose. Um, that random blood glucose might be over 200. And that's just because the blood sugar is spiked after they've had a meal. The difference between that and someone who might have type 2 diabetes is really the symptoms. Like if the blood sugar is high enough for a chronic enough period of time to the point where it's causing these symptoms, then you get concerned about type 2. Um, you can also do an oral glucose tolerance test. Um, and that, if you're interpreting the results of that, it's at least 200 mg per deciliter after 2 hours. I usually don't see the glucose tolerance test in the setting of family medicine. Like sometimes you'll see it in OB-GYN to screen for gestational diabetes, but I mean, still, it's one of the screening tests. Um, but I'll make a comment here that the reason, it's at least 200 and it's after 2 hours. So this similarly applies, or it's a very similar concept to the random blood glucose in that, anybody that gets a glucose load will have an elevated blood sugar. But in this case, the glucose tolerance test is at least 200 after 2 hours. In a normal person, they've had the glucose and then they're producing insulin and their body is responding to the insulin, so they're clearing the glucose. But for someone that has diabetes who has insulin resistance and they're not responding to insulin, they can't clear um, glucose, and so it'll stay elevated after 2 hours. Um, and then you can also test a HbA1c, which is diagnostic of diabetes if it's at least 6.5%. Okay. So we've talked a lot about the diagnosis and screening of type 2 diabetes, um, but it doesn't stop there. You have to, there are additional screening tests to get once someone is diagnosed with type 2. And so that includes things like yearly eye and foot exams, um, urine albumin to creatinine ratio, and serum creatinine. So the eye exam is to screen for like diabetic retinopathy. The foot exams I think are uniquely important because those like screen for diabetic neuropathy. And so, if they don't have sensation in their feet, um, then they can like redistribute the load bearing, like their weight bearing posture as they're walking around and doing stuff. Um, and then that can cause like micro trauma to the area, but since they have neuropathy, they don't feel that. And so then, bacteria can see this little micro trauma and um, and then can cause like a diabetic foot ulcer. And then if that goes all the way to the bone, then the bone can get infected. So then you'll have diabetic osteomyelitis. So that's why you want to do this foot exam to screen for neuropathy. Um, the urine albumin to creatinine ratio and then the serum creatinine, those are more to screen for things like diabetic nephropathy or diabetic like kidney disease, just because of like the non-enzymatic like glycation of the glomerular basement membrane. So then you can have like renal failure. So that's what you want to get on a yearly basis. You also want to get a lipid panel every 5 years for someone that has type 2 diabetes. Okay, another high yield screening thing for family medicine and surgery as well, is colorectal cancer. Um, so, like the general guideline for someone who doesn't have any risk factors for colorectal cancer, they get a colonoscopy starting at 45 every 10 years. So, 45 until 75, you get a colonoscopy every 10 years, assuming that colonoscopy is negative each time. Um, if there is any family history of colon cancer, you subtract the age at which that person was diagnosed. You subtract 10. So let's say, for example, um, someone comes to the office and they're like, well, my dad had colon cancer diagnosed when he was 50. So you subtract 10 from 50, that gives you 40. So that patient who has the family history, they start with colonoscopies at 40 and then they continue every 10 years until 75. So 45 for anybody that just like doesn't have any family history. If there is family history, then you start earlier. If you subtract 10 from the family member, whatever comes first. So 45, but if the family history subtracted by 10 is earlier than 45, then you start then. There are also like some other indications for colonoscopies, but that's more in the surgery realm. So I'll talk about that in surgery, not in family med. Okay. So regarding colorectal cancer, there's also like the fecal occult blood test, which you can do every year. And then I think there's like an immune test that they can do every 5 years. But I think the highest yield thing to know is the best recommendation is a colonoscopy. Okay. So pregnancy stuff. So pregnancy or a pregnant mother comes to the office for a first routine prenatal visit. What tests does she get? Spoiler alert, it's a lot. So you do all of these. So you get a pap smear, you get an HIV test, you get a urinalysis, you get an STD screen, so like chlamydia, gonorrhea. Um, you get an HBV, so hepatitis B test. You test their rubella titers, and then you get a blood type. So there's a lot of tests that you get for the first routine prenatal visit, and that's ultimately to see if there are any conditions that could put the baby at risk. And they're all listed here. So let's say, for example, you get the blood type, and mom's blood type is A negative. So she's rhesus and she's Rh negative. What do you do next? Least invasive possible, you test dad's blood type. So let's say, for example, dad's blood type is A positive. Then what? Um, In this case, you give a RhoGAM anywhere between um, 24 to 28 weeks of gestation. So the general indication is you give a RhoGAM at 24 to 28 weeks gestation for Rh negative mothers with confirmed or suspected Rh positive infants. There are some other indications or situations in which you give the RhoGAM earlier, and generally that's like if there's a suspected or a confirmed fetal-maternal hemorrhage. So anytime you're doing like an invasive procedure like an amniocentesis or like percutaneous umbilical cord blood sampling, or if there's like any sort of an abortion, so like a threatened abortion, spontaneous abortion, or like an abortion done in the office, so on and so forth. Anytime you're suspecting that blood from the baby has transferred over to an Rh negative mom, then you give the RhoGAM. Um, let's see. But that usually falls more under the scope of OB/GYN, so not necessarily for family med. Um, what else was I? Oh yeah. So the reason why you give the RhoGAM to a Rh negative mom is because Rh negative moms produce an IgM against the Rh antigen, and so anytime the fetus or anytime fetal blood that is Rh positive goes into mom, the IgM antibodies in mom can recognize the Rh positive antigen. And so then there'll be like some class switching from IgM to IgG. And then those IgG antibodies can cross the placenta and attack the baby. Um, for the first pregnancy, that doesn't really happen. So it's not the first pregnancy that's at risk, but subsequent pregnancies that have Rh positive infants, those IgG antibodies can cross the placenta and attack the baby. And so you'll have like hemolytic anemia of the baby, you'll have like hydrops fetalis, so on and so forth, all very bad things. Um, so you give the RhoGAM, which basically like blinds mom's IgM antibodies from like recognizing and then mounting the whole response to Rh antigens. Okay. Um, Another thing that you do during pregnancy is you give the Tdap. Um, so yeah, every pregnancy you give the Tdap anywhere between 27 to 36 weeks of gestation. Okay. On the topic of vaccines, there are also contraindicated vaccines that you do not give in pregnancy, and those are live attenuated vaccines like the MMR vaccine, the varicella vaccine, and HPV. Just because there's like some concern that the live but weak virus will make it into the baby and can like infect the baby. Out of an abundance of caution, those are not indicated in pregnancy. Um, One additional comment is the flu vaccine is fine to give in pregnancy if it's the flu vaccine that is like the killed vaccine. It's not live attenuated. I don't think they have live attenuated flu vaccines anymore, but like at one point in time, there was a live attenuated flu vaccine that is contraindicated in pregnancy. Okay. Um, in addition to USPSTF stuff, joint pain is also extraordinarily high yield in family medicine, just because it's like a massive differential and it's just very high yield. So, for example, there's a 68-year-old female comes to the office. She has a chief complaint of right and left wrist stiffness and pain of 12 months duration. Pain is worse in the morning. Vitals are stable. Bilateral wrists are boggy and tender to palpation. And then what is the most likely diagnosis in this case? This is most likely rheumatoid arthritis. And so the features that suggest rheumatoid arthritis is it's like bilateral wrist pain, wrist stiffness and pain. It's worse in the morning. So if there's joint pain that is worse in the morning and gets better with like rubbing it or moving it around, that could be an arrow in the direction of rheumatoid arthritis. On physical exam, boggy and tender wrists are consistent with rheumatoid arthritis. Um, Sometimes the patients might have like fever or weight loss, but we'll talk about the extra-articular manifestations of rheumatoid arthritis coming up. Anyway, so you've made the diagnosis of rheumatoid arthritis, then you have to treat it, right? So I've seen this question a lot of times actually. Which of the following medications is better to treat flares or like pain of associated with rheumatoid arthritis, acetaminophen or ibuprofen? And at first glance, you might think that these are the same, but they're actually not. So ibuprofen is the better choice here um, because it's an NSAID that reduces inflammation like at the affected joint, whereas acetaminophen works at the CNS to reduce like the sensation of pain. I mean, that's kind of how I conceptualize it. The actual mechanism of acetaminophen isn't like entirely characterized, but it has more activity at the CNS. One other thing that I forgot to mention for like diagnostic features of rheumatoid arthritis, the morning pain and stiffness. So anyone who has like rheumatoid arthritis they might have morning pain and stiffness. that like gets better with like moving it or rubbing it around. Um, and that kind of is different from osteoarthritis, where osteoarthritis usually gets worse with use and worse with activity, because it's like, the cartilage has degenerated, and so you're just kind of like putting bone against bone in osteoarthritis, which is painful. But in rheumatoid arthritis, it's like inflammation of the joint space. Um, so, if you're sleeping and you're not really moving around all that much, all of the like cytokines and immune inflammatory cells and so on and so forth can accumulate in the joint spaces, and then that causes the pain in the morning. But then as the patient is like moving the wrist around and rubbing it, um, it's kind of getting circulation to like increased circulation to and from that inflamed joint, which, gets rid of all of the inflammatory buildup, so to speak. Or at least that's how I was taught it and like conceptualized it during preclinicals. So that's how you can differentiate between rheumatoid and osteoarthritis. Okay. Um, you might also be asked about the other medications that are used for like longer term treatment of rheumatoid arthritis. And so those are things like DMARDs, so methotrexate and TNF alpha inhibitors, um, plus or minus steroids. You usually get into the realm of steroids if it's like there are no other options that are working for the patient. Like it's an end, not end stage per se, but like everything else has been exhausted. Um, so let's say, for example, you're considering starting someone on a TNF alpha inhibitor. Before you start the TNF alpha inhibitor, like infliximab, you want to screen for tuberculosis exposure risk. So you can ask like history, like have you ever worked in like healthcare, or were you ever incarcerated, immigrant from a country with like endemic uh, tuberculosis, things like that. And then you'll also want to get like an IFN gamma release assay or the skin test. And the reason why is like if you start someone on TNF alpha inhibitors, that interferes with the branch of the immune system that basically keeps latent TB in check. So if you get rid of that immune response, then TB can reactivate and proliferate. And, you're making the rheumatoid arthritis better, but TB is coming back, which is not good. Okay. Um, Longer term scale of things like chronic manifestations of rheumatoid arthritis include things like ulnar digit deviation if it's in the hands, the swan neck deformity of the fingers, and you can also have cervical subluxation. And so that's important because uh, if someone has rheumatoid arthritis and they're going for a surgery that needs like general anesthesia, i.e., they need intubation, you want to get an X-ray of the neck to screen for cervical subluxation in case, like, um, as they're being intubated, you cause like fracture um, in the like an atlantoaxial fracture, um, which is again not good. So you get that X-ray. The other like condition that is associated with cervical subluxation is Down syndrome. So trisomy 21 is the other thing that you want to keep an eye out for regarding cervical subluxation. Okay. Um, the extra-articular symptoms of rheumatoid arthritis, there are a ton because it's like a systemic inflammatory disease. So like all of the body systems can be affected. So systemically, you can have like fever, weight loss, fatigue. From a cardiovascular standpoint, you can have atherosclerosis. You can have like coronary atherosclerosis, which can give someone a heart attack or heart failure. You can have like vasculitis. You can have pericarditis. You can have rheumatoid nodules, which are like those bulges under the skin. You can have anemia of chronic disease. So if they have a decreased hemoglobin and an elevated ferritin, you'll want to think about anemia of chronic disease. Um, you can, from a pulmonary standpoint, you can have fibrotic lung disease, you can have effusions, you can have nodules, and you can have pulmonary hypertension. Um, you can also have Sjogren disease, which is like the immune attack of the lacrimal and salivary glands. So you're not producing tears or saliva. You can have Raynaud phenomenon, which is like the vasoconstriction of the digits when you're in cold weather. Then you can have like scleritis of the eye. So rheumatoid arthritis can, as the mnemonic says, rheumatoid arthritis can scrap or it scraps the body because it just does everything. Um, I think, yeah, okay, so that's all I wanted to cover. One quick thing, I think I mentioned this before in I think the surgery episode. Um, but pulmonary effusions, like recurrent pulmonary effusions, can be associated with rheumatoid arthritis. So, if someone either has an established diagnosis or they haven't yet been diagnosed with rheumatoid arthritis and they keep coming back to the office or the emergency room, or you just like look in their chart and they have a history of recurrent pulmonary effusions, that could be an extra-articular symptom of rheumatoid arthritis. But keep an eye out for history and stuff because it can also be associated with like malignancy or tuberculosis, recurrent effusions, that is. Okay. Here's another vignette, and here's a picture. 70-year-old male comes to the office. Again, they have right and left finger stiffness and pain. The pain is variable throughout the day, but it's progressed to the point where it impairs activities of daily living. He's a retired salesman. And then here is a photograph of the hands. So you have some like enlarged joints here on both sides. What is the most likely diagnosis in this case? So you might be primed to think, based on the fact that we were talking about rheumatoid arthritis, that this is not rheumatoid arthritis, and you'd be right. This is osteoarthritis, different from rheumatoid arthritis. One other thing that you might see on a clinical vignette is like a positive carpometacarpal grind test, where you like take the thumb and push it into their wrist and like grind it around. That causes pain in osteoarthritis. Um, One other thing that you can, so this patient also has right and left finger stiffness and pain, right? So it's bilateral. So as I said earlier, sometimes you can see bilateral symptoms in rheumatoid arthritis because it's like a systemic inflammation. You can also have bilateral osteoarthritis. It's not as common, right? Because it's more of a mechanical degeneration of the joints, which is different from rheumatoid arthritis. But the distribution of the affected joints is important to consider in osteoarthritis. So if there's like if there's involvement of the distal interphalangeal joints that we can kind of see here, so like the DIP and the proximal interphalangeal joints, so the PIPs here, um, those are classically associated with osteoarthritis, whereas in rheumatoid arthritis, those are usually like the more proximal synovial joints because that's ultimately what is affected. So you can still have um, PIP joint involvement, but you'll also have like the metacarpal phalangeal joints and you'll have the wrists involved in rheumatoid arthritis. Um, so you can have it like in the wrists, you can also have it like in the ankles, which you won't necessarily have in osteoarthritis. Um, Another thing that's important to keep in mind is osteoarthritis can affect the spine, whereas rheumatoid arthritis, not so much, with the exception of the atlantoaxial cervical subluxation. But like like the thoracic and the lumbar vertebra can be affected by osteoarthritis. Um, okay. Another thing that you can use to like take out, or like, you might look at an X-ray of the affected joint of someone that has osteoarthritis, and you'll be asked to pick out the most likely findings. That includes things like joint space narrowing from osteophytosis, which are like those little bony spurs. And then you'll also see subchondral sclerosis in um, in an X-ray. You can also see things like, I think, fibrocystic changes is what it's described, um, or like cysts, subchondral cysts maybe, on an MRI. But I think the more important thing is to look at the X-rays because I think that's what's tested. I only picked that up from my radiology rotation, the MRI stuff, but I would just pay attention to the X-ray stuff. Okay, so we've made the diagnosis of osteoarthritis, and then of course we have to treat it. So that includes like physical therapy and braces to reduce range of motion and build strength to like use the joints appropriately and to prevent like unnecessary wear and tear. But those take a really long time for the symptoms to resolve. So in that case, like if they need immediate symptom resolvement or improvement, resolution is what I was looking for. You give them NSAIDs, just to reduce the inflammation and sensation of pain. So ibuprofen. Um, okay. If like all of these other options have been exhausted and they're still having pain, you can consider steroid injections, for like a short-term relief, but that doesn't like address the underlying cause of the pain. So that's why there's a question mark here. This is really like you pick this if everything else is not working. So let's say, for example, you get to a multiple choice question like this, and it's like, he's diagnosed with osteoarthritis. He started on physical therapy and braces. He has been taking multiple, he's been using NSAIDs for multiple weeks now and has minimal symptom involvement or improvement. What is the next step? In that case, you would want to consider a steroid injection. Okay. Continuing with joint pain, um, a 60-year-old male presents to the ED with excruciating pain of the great toe. He's currently on a backpacking trip with his friends and was awakened by the pain while sleeping in the forest. He takes hydrochlorothiazide for hypertension. Temperature is 37, pulse is 100, blood pressure is 125 over 85, respiratory rate is 18. On exam, he's in severe pain. The left great toe is swollen, erythematous, warm, and exquisitely tender to light touch. And it's shown in the picture. Which of the following is the most likely diagnosis? A, wolf spider bite. B, snake bite. C, flexor tendinosynovitis of the foot. D, gout. Or E, metatarsal stress fracture. So again, like I said, joint pain can cause a lot of, or the differential for joint pain can be very broad. Um, and this is an example of that. So this is um, gout. And I think we'll talk. Yeah. So the main picture, the main reasons why you're thinking about gout is because, well, actually, I'll get into that in a second. So the predisposing, there's one factor or there's one detail in this patient's history that is like a likely predisposing risk factor for gout. And in this case, it is he takes hydrochlorothiazide for hypertension. So hydrochlorothiazide can cause hyperuricemia, which, if there's elevated uric acid, then that can precipitate in classically the metacarpophalangeal joint of the great toe, which is in this case. Um, so what other important things? So usually like it's associated with these people, it might be like they have a purine rich diet, so they're like eating seafood all the time, or if they have like wine all the time. It might also be like, in this case with hydrochlorothiazide. Um, you can also have, um, where was I going with this? Hydrochlorothiazide, hyperuricemia. Oh, so this guy, he was like sleeping in the forest. And so whenever there's like not a whole lot of movement of the joint, especially like in distal joints, like the metacarpophalangeal joint of the great toe, um, like that stasis with like a decreased temperature of that extremity can um, cause uric acid crystal precipitation, which can cause a gout flare. Um, the reason you might, this guy was backpacking and he was in the wilderness and he was, sleeping, and then all of a sudden he was like super exquisite pain. So things like a wolf spider bite or a snake bite could be possible, but those like a wolf spider bite is usually associated with like an ulcer with like a necrotic eschar, um, which this might look like the little bite here, but if you look at the little like light artifact, this is all of the skin is intact. There's no ulcer. And the same thing would go with snake bite. Snake bite, you might also have like extending erythema, things like that, but that will be more in like a trauma surgery episode. Um, Flexor tenosynovitis of the foot, and this is more on like the extensor side or on the lateral side. Flexor tenosynovitis would be like on the dorsal aspect of the foot. They would also be febrile, maybe. It would, the erythema would be different. So the pattern in the clinical presentation isn't as consistent. They might also like flexor tenosynovitis doesn't present as acutely as a gout flare does. It's still acute, but it would more be on like the time course of like a day or so, where it just keeps getting worse and worse. And then a metatarsal stress fracture again is could be associated with someone who's like doing a ton of walking, but it's usually like in the like super athletic, like more adolescent teenagers who are like super athletic and they're like constantly either running or jumping or sprinting or things like that. And again, you wouldn't have this like tophus on the foot. You would have like maybe erythema, probably not erythema, but you would have like tenderness to like deep palpation of the metatarsal. So again, the picture is different. And again, the time frame of a metatarsal stress fracture is nowhere near as acute um, as gout. Okay, so this was gout. The etiology of it is, as I said before, uric acid crystal precipitation. As I said before, it's associated with a purine-rich diet, so like lots of wine, meat, seafood, or in the patient vignette, um, hydrochlorothiazide use causing hyperuricemia. Um, One other thing that's important to consider for gout, like, these are usually in older adults that have like, this suboptimal diet, so to speak, or like risk factors for gout. Um, One important thing to consider is if gout presents in a child. Um, so if a child comes to the emergency room with gout, um, sometimes you want to think like Lesch-Nyhan syndrome, which is very rare, but it's a deficiency in HGPRT activity, which is like responsible for purine turnover, so on and so forth. Like if that's not working, then you can't break down purines, and then that can cause uric acid crystal precipitation. Um, so if someone comes to the emergency room with suspected diagnosis of gout, like I mean, you can't make a clinical diagnosis of gout per se. You have to do a joint aspiration and analysis. So the most important thing to take away from this is you always tap a red hot joint. So if it's like super red, if it's hot, if it's inflamed, if it's painful, you aspirate it and you see what's inside. So the results of the joint aspiration and analysis will tell you like what's causing the joint pain. So if it's gout, you'll have an elevated white blood cell count. You'll have needle-shaped negatively birefringent crystals. That's like a super high yield buzzword for gout vignettes on shelves and step exams. Um, the specific white blood cell count, like the degree to which it's elevated, might tell you what kind of like what kind of inflammatory arthritis is going on. Um, so like one other important thing to consider for someone who comes to the emergency room with like a super painful red hot joint is septic arthritis. Um, you'll usually go down the route of thinking about septic arthritis if they have like a fever and systemic symptoms. But if you have septic arthritis and you aspirate and look at the joint, you'll have a septic arthritis. Like if it is septic arthritis, you'll have a white blood cell count over 100,000. Whereas in the case of gout, you won't have as high of a white blood cell count. Um, but really, the thing that drives home the diagnosis of gout is this needle-shaped negatively birefringent crystal result on aspiration. The management of gout is also important to keep in mind. There's two phases. There's like the management of the acute phase and then the management of chronic gout. So the acute management of gout includes things like NSAIDs and colchicine. These have to be given like as soon as possible to reduce additional inflammation and like neutrophil uh, recruitment to the area, which therefore reduces pain and inflammation. Um, for chronic management of gout, you start thinking about things like allopurinol, febuxostat, and probenecid, in addition to like lifestyle modifications if those are feasible. Um, so if someone comes into the emergency room and they have a gout flare, you start with the NSAIDs and colchicine. You don't start with like allopurinol. That's usually in the longer term management. Okay. Um, Another similar thing to gout is pseudogout, which basically is the same thing. But the difference is instead of uric acid crystal deposition, it's calcium pyrophosphate deposition. So another name for pseudogout is CPPD or calcium pyrophosphate deposition disease. Um, the evaluation is the exact same thing. So evaluate very similar to gout, always tap a red hot joint. And instead of the needle-shaped negatively birefringent crystals, you'll have envelope-shaped positively birefringent crystals. Um, you might also see, like, I'm just now remembering, if you look at an X-ray of someone that has pseudogout, you'll see, I'm forgetting the word, but normally like a joint space is dark, so you'll have like the bone. Maybe I can draw it. I don't know. But like normally you'll have like a radiolucent space between the bones, right? That's the joint space. But in CPPD, you'll have like a radiopaque, like a white sliver in the joint. And I'm forgetting, I wish I remember what that term was. But that's associated with CPPD. Um, I think it's like calcinosis, maybe. Anyway, um, that's what you'll see in pseudogout. Management of pseudogout is the same as gout for acute flares. For chronic flares, not so much because, right, calcium pyrophosphate deposition is not uric acid deposition. So things like allopurinol, febuxostat, and probenecid, those will reduce your purine turnover, or those will reduce the uric acid accumulation. So that won't help with calcium pyrophosphate deposition. I don't think there's any management for chronic pseudo-gout. So NSAIDs and or I'm sorry, NSAIDs and colchicine for acute pseudo-gout flares. Um, okay, before I get to this vignette, the one other thing that I want to say for gout is you'll also see on the picture, if I go back to the picture, usually for people that have acute or chronic gout, they'll have these like really big bulges of the joint. Those are called tophi. Um, you can also see these on X-ray, which are like radiopaque growths almost like in the joint. And that's just like the chronic deposition of uric acid crystals. Okay, so here's the next vignette. I think we're coming up on the end. We're almost there. And we're still talking about joint pain. So we have a 40-year-old female with no significant history. She presents with increasingly severe left shoulder pain and weakness for the past 2 weeks. She said she was doing garden work when she started noticing the pain. Vitally, she's stable. Physical exam discloses pain with active and passive range of motion of the left shoulder. The range of motion is also decreased. Which of the following, or what is the most likely diagnosis in this case? Um, so unilateral joint pain with active and passive range of motion, and then also decreased range of motion. This is consistent with adhesive capsulitis or frozen shoulder. Um, okay, so the management of adhesive capsulitis is really like supportive care, physical therapy, and it usually like it takes a while for these kind of symptoms to resolve. Um, but it's usually like self-limited. Um, okay, before we get into the next subject, I think, yeah, that's all I wanted to say. Okay, so another high yield topic on family medicine is like vascular disease. Um, so we'll just get started with the vignette. I think this is the last topic that I'm going over on this episode, and then we'll be done. Um, so there's an older adult, they present with a couple months of leg pain while walking, and he says he has to take frequent breaks, currently smokes, has a 20-pack year history, has normal vitals, and then on physical exam, the dorsalis pedis pulses are diminished bilaterally. What is the next best step in evaluation of this patient? You want to get an ankle brachial index to evaluate for well, what is the most likely diagnosis? So you get the ankle brachial index and it's less than zero point 0.9. So you get this to check for peripheral arterial disease or PAD. Um, so the ankle brachial index is like you measure the blood pressure between the dorsalis pedis and well, it's the ankle and the brachial blood pressure. And if there's a difference between the two, then you're suspecting um, peripheral arterial disease. So, and that's just like diminished blood flow to those arteries from like atherosclerosis or something like that, which, clinically shows up as the decreased dorsalis pedis pulses and then the decreased ankle brachial index. So you've diagnosed this patient with peripheral arterial disease. What do you do next? The first thing that you do is you stop smoking and you do lifestyle interventions. So tell the patient stop smoking, um, continue with like regular physical exercise, have a healthy diet, all those great things. So that's the first thing that you do. And if those don't work, or if they're, not working as quickly as you would, or as the patient would like it to, then you consider things like physical therapy, or exercise therapy. I think I read somewhere that it's like observed exercise therapy to like make sure that they're actually exercising. Um, but I'm not sure why that's like specifically for PAD. If those don't work, or if they're still having symptoms, the medication cilostazol is good for symptomatic management. So, for example, this guy who has pain while walking, um, that's like claudication, and that is well managed with cilostazol. But that's good for symptom management, not necessarily for like addressing the cause of peripheral arterial disease, which is why you stop smoking and why exercise therapy is good. If that like doesn't work, you also want to consider going down the line of like advanced imaging, like angiography, to see whether or not you can do like an intervention. So like either a stent or vascular surgery or things like that. Um, but importantly, let's say, for example, on a multiple choice exam, you have like the ankle brachial index or advanced imaging. You would want to go with the ankle brachial index first, before going to advanced imaging. Like this is like almost a last line or like end of the road type deal to manage or evaluate and manage someone with PAD. And then, so as I was saying before, advanced imaging leading to a procedure like surgery or a stent. Okay. Similar vignette, 60-year-old male comes to the office with a chief concern of erectile dysfunction, has been with his wife of 30 years, but has trouble achieving an erection for the past few weeks. Has bilateral thigh pain while walking. Again, currently smokes, has a 20-pack year history. Vitals are within normal limits. Femoral pulses are diminished. And then what is the most likely diagnosis? So again, we're seeing some claudication, right? Like there's bilateral thigh pain while walking, but there's also erectile dysfunction, and then of course he's smoking. So this is a variant of peripheral arterial disease called Leriche syndrome, which is a triad of claudication, erectile dysfunction, and diminished femoral pulses. Again, you get an ankle brachial index, and it would be consistent with PAD, right? Because it's a variant of PAD, so you would have the less than zero point 0.9. Um, and then, so before I get to the, so I don't know, I said, yeah, Leriche syndrome, most likely diagnosis, PAD. I don't know why I duplicated that here. Um, One quick comment on the ankle brachial index. I haven't seen it mentioned too much on practice exams, but like just for the sake of understanding the ABI, you can also have an elevated ankle brachial index. Like if it's greater than, I think 1.3 is the cutoff. Um, but if there's an elevated ankle brachial index, then that's usually associated with like I think it's like calcification or like stiff vessels, just because there's like, the walls are so much stiffer, so the pressure in the chamber increases. And so that's why you would have an elevated ankle brachial index. So if you ever see an elevated ankle brachial index, that's usually in the setting of like stiff vessels as opposed to PAD. Okay, so um, I think this is the same thing. So Leriche syndrome, again, it's a variant of peripheral arterial disease. So you do the exact same thing, um, as if this was peripheral arterial disease. So the same management that we were talking about before. Um, okay, this is the last, I think like a very high yield. I'm pretty sure I've seen this on like every single test that I've taken. Um, Actually, I'm not sure. I don't remember, but everybody talks about this. So regardless, it's a very high yield um, thing. But if someone comes to the office and they have an ulcer over the medial malleolus, it's a venous stasis ulcer. Just pick that and move on. I mean, I've seen like Divine Intervention, shout out to Divine Intervention, but he like says the exact same thing. Anytime you see medial malleolus in an ulcer, pick venous stasis and like move on. Um, but so in addition to like, yes, this is a venous stasis ulcer, the management of the venous stasis ulcer over the medial malleolus includes things like compression stockings, physical therapy, dressings, like regular dressings and debridement to prevent infection, and to ultimately like improve or resolve the venous stasis ulcer. Okay, that is the end of this episode. Lots of like USPSTF stuff, joint pain, vascular disease. There's still a ton of other um, things to talk about in family medicine, but I wanted to make these digestible, hence why I'm making a series instead of just a video for each shelf. As always, feel free to leave a comment on like feedback on how this can be improved, or if you have any requests for like additional topics to go over in the future. Really, this is just my passion project. I just like making this. And so if you guys find anything super helpful in particular, I'd be happy to hear about it so I can make it better for you. But with that being said, if you are currently studying for your shelf or if you're currently studying for STEP, I wish you the best. You'll do great, given that you have made it to the end of this episode. Um, but otherwise, I wish you the best and take care.